So Dr. Catanese is an associate professor of medicine, neurology at McMaster University and a stroke neurologist at Hamilton General Hospital. She is the regional stroke lead for hyperacute stroke care and stroke unit care at the Central South Stroke Network and an investigator at the Population Health Research Institute. She also serves as the director of the McMaster Stroke Fellowship Program. She completed her training in neurology at Boston University, followed by a fellowship in vascular neurology at Harvard Medical School and training in biostatistics at Harvard University. Dr. Catanese has participated in multiple international trials testing novel therapies in acute ischemic stroke patients and has multiple publications in high-impact journals. She holds several grants, is involved in the Canadian Stroke Best Practice Recommendations, and serves as an associate editor of the Stroke Journal and full reviewer for CIHR. Her research interests include hyperacute stroke therapies, acute stroke neuroimaging, stroke in women, cerebrovascular complications of COVID-19, and acute management of intracranial hemorrhage. So welcome to Dr. Catanese.
Thank you so much for inviting me to present today, and we'll try to do this as interactive as possible. And thank you so much for your amazing questions. Actually, many of them overlapped, so that gives me a possibility to sort of go over some things, some themes that are most important to you. So going down the slides here, conflicts of interest, I don't really have many, especially for this presentation, but I do engage and work with a lot of companies in acute stroke. And I am the local PI of the hyperacute stroke trials here at the General. So next slide, please. All right, so the first question was, how do we approach patients who do not meet provincial PROM criteria or are more atypical presentations? So for example, visual disturbances. So this is a great question. Let's go down, please. So that brings me into talking a little bit about what are the most common presentations. And when you are doing something like the FAST score, for example, how many patients or what's the proportion of patients that are in strokes that you are actually picking up? So this is really one of the one of my favorite papers, looking at what are the type of strokes that present to large academic centers. So this is a retrospective analysis of 465 patients that presented to either a large academic center or a large community hospital. They have more than 1,000 ghost strokes a year. What they did is to look at the patterns of stroke presentations to these large academic centers. And they looked at the proportion of patients that had missed strokes, which I will link to another question that came up. So when we look at the patterns of stroke presenting to our emergency department, it's pretty much what we know statistically is the most common type of stroke. So obviously, first of all, 90%, 85% will be ischemic, and just a 15% will be hemorrhagic. That's in our population. But of those that are ischemic, 70% come from the anterior circulation and 30% come from the posterior circulation, okay? And these are the proportion of symptoms that are more commonly reported by patients. So you can see here, focal weakness is about 65%, okay? So someone without focal weakness, it's overall less likely, and this is the basis of the LANS score, right? Heavily focused on motor deficits. Speech impairment, a third or more of patients will have that. About a third also we have aphasia, right? So these are the main things. Then we have things like focal numbness, meaning half of the body, one leg, one arm. 20% will have vision changes, either in the form of the, vision loss or double vision. 18% will have gaze preference. 17% will be lethargic. 15%, this is not a small proportion, but 15% will have just dizziness, which is quite non-specific. 12% will have headaches, 9% dysmenorrhea, which is incoordination of the arms or the trunk, neglect, and a smaller proportion will have nausea and vomiting, which we know can originate from the posterior circulation mainly, syncope or seizure, which is a fairly rare presentation of stroke. I actually have very low suspicion for stroke when we see someone with syncope and in isolation. If they have focal deficits, focal weakness on top of it, then that's a different story. So what are the patterns? So, okay, what I highlighted here for you to kind of see is in colors, what are the deficits that are only an anterior circulation deficit, only a posterior circulation, or both? Okay, and there is a little bit of overlap here, but such as just to give you an idea. So focal weakness is largely an anterior circulation, but obviously can happen in posterior circulation. I should have put that in red actually. So it picks up both. Speech impairment, same. Aphasia is largely an anterior circulation issue. Then we have things like focal numbness, vision changes, gaze preference, both. And then the less common symptoms here, for half of the table down, are actually more posterior circulation, okay? And those are more rare. So that means if you look there, the FAST score, we actually pick up a fair amount of patients, right? And I will talk about sensitivities and specificities later. But basically, you know, face arm weakness, speech impairment in the form of dysarthria aphasia, and that's the FAST score, right? And that's the reason why that is largely utilized with high sensitivity and specificity. It does pick up most of the deficits. That doesn't mean we shouldn't be aware of the rest, because posterior circulation strokes are more lethal and disabling than anterior circulation strokes. So it's really important that we are aware that things that are less specific, like being dizzy with nausea and vomiting, can also be a presentation of stroke and therefore these patients require further assessment. So let's go down. So when looking at the paramedic prompt card for acute stroke bypass protocol, so the question was, what do we do, you know, when they're not quite within these? Well, first of all, they do include the same features. And the reason being, again, now you know, is that the motor, the focal weakness will be largely overrepresented in patients that have strokes, as well as having some slurred speech or language impairment. But what to do when there are symptoms that now you know, or you probably knew already, that can look like a stroke, okay? And you feel that you think that there may be a stroke because patients develop them suddenly and they are very incapacitated, maybe by the nausea, vomiting, the vertigo, and they cannot walk. So overall, I think it is good practice that if you think it's a possible stroke, just report it as such to receiving ED. Labeling a case as a stroke or a possible stroke will trigger a pre-alert and a discussion before the patient arrives if they are within the window, even if they are outside the actual protocol, so to speak. A lot of times, I can tell you a number of times that I'm called and they tell me, you know, not the typical symptoms, but they have this and this and that. And I'm like, yes, that can be a posterior circulation stroke. We're coming. This can help identify a stroke patient faster, save time, and increase access to treatment. The worst case scenario, you know, when we have a conversation at the hospital, ED and stroke MDs, we will decide whether we activate the code stroke or not. But at least that came up as a possibility. And that's sometimes all we need to trigger the whole process and do things in a more effective and efficient manner. So going down, thank you. These are some of the contraindications of the paramedic stroke card, and I thought that they were interesting. I just wanted to highlight some things so you keep them in mind. So for example, things like having low sugars, right? Carefully, it could still be a stroke. So treat it, but if the patient doesn't get better and the symptoms do not resolve fully, that patient can still be a stroke, especially our patients are diabetic and they fall and they're an unknown time down and they could be hypoglycemic by the time they arrive. So that doesn't exclude it. Okay, that doesn't exclude someone, and it's also it is outlined there. Seizure at onset. Well, careful, because 5% of stroke patients present with seizure. Actually, seizure, nuanced seizure in the adult, the most common cause is a stroke. Okay, so keep that in mind. If there is focality on top of the seizure, then that's important to note. I'm not sure why a Glasgow Coma scale less than 10. I'm not sure if anyone can post it in the chat why that would be a contraindication. I really thought about it and I'm not sure. A lot of our patients do have a GCS less than 10. Terminally ill or palliative. What, and again, this is all things to now discuss and think a little bit about. What if the life expectancy is more than 3 months? What if it is 1 year? What if they want to pursue treatment? I cannot tell you the number of times we've treated palliative patients, terminal cancers, and we gave them the chance to live a life without disability for those 6 months they have left, a year they have left, 2 years they have left. We do not exclude patients in the clinical setting based on palliative care. Yes, based on life expectancy, generally speaking, if it is less than 3 months. So just to put it out there. Going down, we have question number 2. That was a really good question, by the way. Are there key signs or symptoms we can pick up in patients with posterior circulation strokes? And this is really an important question. And I touch upon that, of course, but we're going to go a little bit deeper. And what is the key information we need to communicate during the patch or TOA? Okay, let's take a look at that. So going back to this study, okay, what are the patients that are misdiagnosed? So this is a large tertiary academic center, okay, and a large community center. 22% of stroke patients that arrived to ED were actually misdiagnosed, okay? That means that the diagnosis was missed altogether until later, or they were diagnosed late and they were not candidates for treatment. That was half of them occur pretty much at the academic hospital and half at the community hospital. And a third presented within 3 hours. So these are patients that we will definitely consider for treatment if they have disabling deficits. And 11% presented within 3 to 6 hours. So half of them almost were actually potential candidates for treatment. So this is a huge problem. And this, again, happened in an academic center, high volume. So 37% of posterior circulation strokes were misdiagnosed compared to 16% of the anterior circulation. So you're all of us are more likely to misdiagnose posterior circulation stroke compared to an anterior circulation one, 3 times more likely. And we should be aware of this. What are the symptoms, posterior circulation, that are more typically associated with missing diagnosis? That's issues walking. A person who tells you suddenly, I have nausea, vomiting, vertigo, I can't walk. When they say I can't walk, then that should make you think, oh, that's not normal. Dizziness, it can come in many shapes or forms. I would actually give up on trying to identify what kind of dizziness, because first of all, it is very difficult for a patient sometimes to articulate what they feel. It could be a sense of being on a boat where you feel like you have a sense of motion, or you have just imbalance, or they can just explain it. Sometimes it's lightheadedness. Again, it is a very difficult symptom. And I'm happy if they just say dizziness. Vision changes, that could be double vision or vision loss, could be in one eye or one side. Dysmetria, which is in coordination, okay, could be in coordination of your arms or your legs, headaches, and nausea and vomiting. And what's the common theme about these is that they are non-focal, okay? When we say non-focal, means that we can have headaches without having a stroke, right? It doesn't mean that I can identify an area of the brain, a vascular territory, from nausea and vomiting. Okay, I can in isolation. So they are not necessarily focal, they are more non-specific, and that's what is the main challenge here in identifying these patients. Going down, please. Thank you very much. So what are the predictors of missed strokes? Okay, those non-specific symptoms. Patients that come with nausea and vomiting, they are 4 times more likely to be misdiagnosed. Prior history of stroke, prior history of stroke, because people think, oh, you had a stroke, it is hard to know what's new, what's old, and err on the side of saying, oh, it's probably old. Dizziness, almost 2 times more likely. And they're all posterior circulation. So nausea, vomiting, and dizziness are posterior circulation symptoms, right? So you're more likely to misdiagnose. That's why we are more likely to misdiagnose posterior circulation strokes. And the opposite, lower likelihood of misdiagnosis, someone who comes with focal weakness, vision changes, they tell you can't see, or double vision, having a gaze preference is pretty obvious, and having issues articulating words. So going down, please, and please post in the chat if you have any questions, okay? We'll definitely address any other things that may come up as we move forward. If it is not clear, this is the time to ask all those questions. Feel free to do that. Are there any assessments or parts of, and part of that question was, what should we say when we call? Well, you should say the patient had sudden onset, nausea, vomiting, dizziness, and they are unable to walk. What we're looking for when we want to make decisions of whether we trigger a cold stroke or not is whether there is something that will leave the patient disabled. Okay, a posterior circulation stroke generally is the inability to walk. The inability to walk is a huge thing. But if you just say, you know what, he was fine, and suddenly he had this, and it could be a posterior circulation stroke, that's it. We will take it from there, okay? And honestly, sometimes it's very difficult to know. These are not easy things to differentiate whether someone is having an acute GI illness or a vestibulopathy or a stroke, right? Or a posterior circulation stroke. So that we have to use every tool we have, and that generally includes imaging. So as long as you identify a potential stroke, then I think that's exactly what you should be doing. Moving on to this question, are there any assessments, parts of a stroke exam that we should be adding to our practice? Something that may help us spot a stroke, that the typical assessment of facial droop, grip strength, and arm drift may not. Absolutely, amazing question. These are all things that are based on motor deficits. So there is a lot more to that, as we have seen. So one of the scales that is coming up now is quite widely used in the US, actually, and probably will be coming up here in Ontario and in Canada as well. Is the B fast. So it's adding B to fast, B fast. And you can see the 2 items are balance loss. Again, we're talking about not being able to walk or having imbalance. And eyesight changes, so issues with the eyes. Either your eyes you have double vision, or you cannot see either from one eye or one side. Something changed. Sometimes people will say blurry vision, but it started suddenly, right? And it's associated with other things like nausea, vomiting, dizziness. So that also should make you think about the potential for a posterior circulation stroke. So this is an easy one. And how do we assess? So let's go down. Thank you very much. These are some of the things. So if you want to assess for balance, okay, quickly, just make someone walk, right? Can they walk unassisted? Yes or no? If it is a no, then that's an issue. So walking patients, we do this in the emergency department all the time, especially with posterior circulation strokes. A patient with vertigo from an ear problem should be able to walk, okay? It may not be perfect, but they will be able to walk without assistance for the most part. Someone with a stroke in the posterior circulation, most likely not, okay? And then coordination. So there is a test that is very, very simple, and where you ask the patient to touch a nose and touch a finger and go from the nose to the finger. What you want to see is the pathway from the nose to the finger. You see, it should be a straight line. So most of us will draw a straight line with our finger. But, and I don't have the animation here, but if it becomes irregular, so if it is sort of going all over the place, that finger, and it's not drawing a straight pathway, then that could be an incoordination, okay? They cannot coordinate the muscles to keep the finger drawing a straight line, okay? So think about that imaginary straight line, and if it is all over the place, or they are missing their own nose, sometimes they touch the eye, they touch the cheek, that's exactly what we're looking for, okay? So then you can say they have ataxia. That's called appendicular ataxia or incoordination. These two things add a huge amount of value. Honestly, these two things are a huge amount of value to just the motor exam. But there are other things that are easy too. Let's go down, just to keep in mind. So you see someone laying down in the floor or in the bed, the stretcher, and you see that there is a leg that is externally rotated. So there is two options here. One, they have a hip fracture. But if they didn't fall and they just develop sudden onset weakness, then that's weakness. You don't have to even test the leg. Just by looking at this, you know this patient has weakness, okay? So that's an easy observation. It's a huge tool in ischemic stroke or stroke in general, and can give you a lot of information. And going down, this is a simple one, extremely valuable. Strongest predictor of the presence of a large vessel occlusion. Someone whose eyes are stuck on one position, either to the right or the left, this is called gaze deviation. If you see this, I wouldn't check anything else. I would just take it to the hospital, okay? Just, that's it. There's two options always. Obviously, if the patient is talking to you and has the gaze deviation and is not shaking or having seizure-like activity, they're not having a seizure, likely having a stroke with this type of problem. But seizure can also cause the gaze deviation, right? But the two patients will look a little bit different, as you know. Go down, please. Any disconjugation of gaze, okay? Left upper, you see the patient is asked to look to the right and only the right eye moves, the left doesn't, okay. This is a dysfunction of the pons. The pons, the back of the brain, is where the horizontal gaze center is. It moves our eyes right to left, okay? So if the eyes are not moving together, right to left, then that may be a problem with the back of the brain. Again, posterior circulation stroke. You may have that in isolation, or it may have something else. This lower picture here, lower right corner, you can see the left eye is not only a little bit droopy, but it's down and out. We say being down and out is not cool. And that's what happens when you have a cranial nerve 3 palsy, okay? So eye down and out is a cranial nerve 3 palsy, it's a midbrain dysfunction. And the gentleman here on the right, looking straight to the camera, you can see the left eye is higher than the right. So that's called skew deviation. So they are skewed. One eye is higher than the other. That should not happen. They probably will have double vision or nothing. They'll have other posterior circulation symptoms, but that's a posterior circulation. So just going with their finger and say, hey, follow my finger, right and left. If it's normal, good, the pons is functioning. If they are conjugated, then that's fine, right? That's quick and simple. Any disconjugation, think about the back of the brain. That's where the eye movements are. So going down to question 3. Anybody has a question relating to what we're talking about? So I see something coming up here.
Yes, so Dr.
Okay.
Catanese, there is one. Do the symptoms for posterior circulation strokes usually present as one or two isolated symptoms, or is it common to have most of the symptoms discussed present?
Yes, fantastic question. So if we look at the probabilities, and just from my own experience, never in isolation. Generally, a patient will have nausea, vomiting, dizziness, vertigo together. Because what does that mean? They had a cerebellar stroke. They had a cerebellar hit and they got the sudden onset nausea, vomiting, vertigo. They sort of come together. The same with being unable to walk. Generally speaking, they'll have something else. Again, it could be incoordination of arms and legs. Generally, you do find it in the legs too, if you check. It could be some eye irregularities. So generally speaking, you'll find, I would say, 2 or more things in the same patient. And you see that the most common ones, I show there in the table where are the most common ones that you will find. But yes, if you see, so this is the issue when you see nausea, vomiting, dizziness in isolation. What I would say is rarely are these patients don't have anything else. If you really look, vast majority of times you'll find incoordination, inability to walk. That'll be a big one. But if they are in isolation and they study suddenly, that also should make you think this is not this is concerning. Okay, at least we have to watch that person. At least we have to do sometimes imaging to make sure there's nothing going on. Again, it could be tricky, but always remember sudden onset. Normal, minute 1, minute 2, abnormal. That kind of problem is vascular. All right, so great question. Thank you. We'll go into stroke mimics. So refresh other diagnoses that mimic stroke. All right. So this is actually, all of these things are very much related. So let's go down to a mimic. What is a mimic? So a mimic is a condition that is not a stroke, but that looks like a stroke, okay? So 20-25 suspected stroke presentations are actually mimics. So this is a large proportion of the work we do. The work we do is have this patient, looks like a stroke, and then trying to figure out whether it is a stroke or is something else listed here. Most commonly, you know, the sudden onset vertigo, nausea, vomiting. The very most common one is a peripheral vestibular disease, so something like benign positional paroxysmal vertigo. Would be very, very common. Having toxic metabolic problems. So, you know, having a UTI sometimes will make patients look like they are not articulating words well, they are sleepy. And again, we've seen those are symptoms that could be seen in stroke. So they require assessment. Seizures. So 20% of seizures are around 20% can have focal deficits called thoughts paralysis. And those are reversible. These are very tough patients because sometimes if they happen for the first time, you don't know. And again, most common cause of seizure in adults, the new seizure in adults is stroke. So we do need to assess these patients thoroughly. Functional disorders, migraines, having sepsis, having mononeuropathies. Okay, sometimes you have radial pulses and they come with the wrist drop, and we don't know is it central, is it peripheral. Again, all of these things need to be assessed. Any confusion, dementia at baseline, generally dementia at baseline, will sometimes look like aphasia. Important to get really a good baseline for these patients, and others that are non-defined. So, next slide, please. How do these patients differ from the actual strokes? Okay, so here you have a table and what they look, this is a very large sample. This is a nice comprehensive review actually. So they are less like, they have lower NIH point score. So meaning lower deficits. They're generally milder deficits. They tend to be younger because a lot of things like migraines, vestibulopathies, all that kind of affects younger patients. 68% are women, more likely to be than men. They're more likely to have normal blood pressure. Really, normal blood pressure is rare in stroke. It doesn't exclude it, but it's about 5% of our patients that will actually come with a stroke with normal pressure. So normal pressure less likely. And going down the next slide, please. So what are the risk factors? So if you see a patient, you're like, oh, is this a mimic or not? Well, they have milder deficits. They're a woman. And then they have no risk factors. Okay, so not having a risk factor, any of this, or having, they actually have less risk factors, right? It will make it more likely to be a mimic, and having more baseline cognitive impairment or dementia and migraines. Okay, history of cognitive impairment, history of dementia, history of migraines will increase the chances this is a mimic. Again, all these are tools, but it helps you triage that patient. It helps you think about what's the likelihood this is a stroke versus a mimic. At the end of the day, it is very difficult. A lot of times they can look alike and we need an MRI brain. So the good practice will be bring them in and we'll take the time to do imaging, do a full physical exam, and figure this out. Sometimes we give treatment to mimics because we cannot figure it out within the hyperacute time, and that's okay because they have a very low likelihood, very, very low risk of bleeding, very low risk of bleeding. And it happens. Going down, this is a way more serious thing, I think. And this chameleon is serious because the chameleons, the stroke chameleons, are more concerning than the mimics. And I just want to put this in your mind, that what are chameleons? We always talk about mimics and chameleons. Chameleons are actually strokes, okay? These are actually ischemic strokes that present similar to other diseases because either they have a different tempo of onset, so some could be progressive onset, or stuttering, they come and go, or they have symptoms that do not necessarily implicate an arterial territory like nausea, vomiting, dizziness. Okay, that's a chameleon. So posterior circulation strokes are a lot of times present like chameleons. And if chameleons are not identified, they are not treated. Okay, because missing treatment for a mimic, not a big deal, like in terms of thrombolytics, but a chameleon, big deal. So just want to give you one word about this. You have all the chameleons listed there. Those are the most common. Hand weakness, pure motor with monoparesis. So I have either weakness in the hand in isolation, or the arm, or the leg, or just the face. And people think it's actually, it's a nerve issue. Well, if the stroke is small enough and located in a strategic place known as the motor cortex, you can have just hand weakness. This is a stroke in what we call the hand knob. This is a little knob in the brain that if you get a hit in it, will knock down your hand. It will basically look like a wrist drop. The hand is not moving, is not flexing, not extending. The others, chameleons, are largely posterior circulation strokes. And again, going back to the what do we miss more? Oh, well, we miss more the strokes that look like other things. And we should be aware of it, okay? So Berlin syndrome, all of these things, they present in a less, they present without weakness. So that's the first challenge. And the other is that they're less common overall. So you may not have encountered any, and you encountered it for the first time, and then you're like, oh, well, this doesn't look like a stroke, but it started suddenly. So we'll see. Stroke with seizure-like activity. There is a lot of strokes that the patients are shaking, okay? So for example, TIAs, you can have hemi body shaking. Remember that with limb shaky TIA, the patient is wide awake talking to you, and generally has to do with low blood pressure, okay? And then they start having focal deficits, and they are pure motor, okay? Purely motor. The other thing is brainstem. These are the vast majority of patients I see, they are treated as seizures, and this is an issue. The patient suddenly becomes comatose. Nobody looked at the eyes that are disconjugate. The patient is intubated, and then They are moving the legs. Generally, we call it a pontine march. It looks like the patient is marching in bed, comatose. That's a dysfunction of the corticospinal tracts. Okay, it's not a shaking, it's just a march. Once you see it, you will pick it up, but it is quite common, and is easily diagnosed as a seizure and not as a stroke. So chameleons, be aware of those. Going down. Question for the audience, and there's no right or wrong answer here. Is this a mimic or a chameleon? So this is a woman, and she has a rest. You can see the first image, left-sided weakness in the face. You can see the droopy face on the left. When you ask to activate her face, you can only activate the muscles on the right, including the forehead, the eyes, orbicularis, and the lower face. When we ask her to close her eyes, she has this phenomenon. It's called Bell's phenomenon, where the eye goes up and rolls up. You can see the white. So just throw it in the chat. Mimic or chameleon? Don't be shy. Again, no right or wrong answer. Okay, well, I have a few more slides, so. Oh, chameleon, perfect. Thank you, Jenny. Thank you very much. So that is correct. And it's also a mimic. There is no right or wrong answer. So basically, yes, could be a chameleon because it could be a peripheral facial palsy. It's a peripheral facial palsy. A lot of people will look at these and say, oh, it's a Bell's palsy. Well, not so fast. Can also be originally from the brain. And this is where you have to think about it, right? So you have to look at the risk factors and everything else. So what do you have to, it could be a stroke. It could be a pontine stroke, right? In the pons, you can knock down the peripheral fibers. It could still be a pontine stroke. But it could also be a mimic. This actually is Bell's palsy. This is a peripheral facial nerve palsy. And in this case, the girl had a viral infection, and it affected the peripheral. So that's a mimic, right? It's not a stroke, but it can look like it. So these are the challenging ones where, unless it's clear-cut, straightforward young girl without risk factors, and slowly she developed these, a lot of times they have pain in the mastoid and so forth. If you have a 75 with multiple risk factors coming in like this, you probably will do an MRI on that person, right? Full physical exam, look for other things. So just keep it in mind, okay? Alrighty, thank you very much. Let's go to the next slide. Question 4. What happens to the patients who are outside the stroke window? What treatments do they receive? So there's different windows in a way, because TPA window is up to 4.5 hours at this point in time. And EVT can be offered up to 24 hours in selected patients. So I'm not sure if that outside the window was the 24-hour window. I just assume it was the 4.5-hour window or the 6-hour window, but we can still offer endovascular therapy up to 24 hours. Okay, it just has to have special brain imaging, and not everybody will be a candidate for this, but definitely gonna be offered. There is dual antiplatelet therapy that we give that should be given ASAP for patients that are not candidates for revascularization therapies, or a lot of times we start IV heparin because they have thrombosis that are floating around, right? So there is a variety of things. And because these are all time sensitive and stroke tends to recur in the first few days, first 2 days is when we see the vast majority of recurrences, then we want to get these treatments in ASAP. So hope I answered that question. Next slide. Yes, thank you. Okay, assessing stroke patients in pre-existing deficits. This is a really great question. So again, these can be mimics or chameleon, right? If they had a stroke and they had a urinary tract infection, they can be worse. They can have worsening of symptoms, okay? The key there is to ask the patient, did you have these symptoms before? Because a lot of patients had right-sided weakness, for example, just give you an example, that resolves or is very minimal after 3-5 years. Then they get a urinary tract infection, for example, they may not have been aware of, and the right-sided weakness comes back. We call that recrudescence. That's a true recrudescence of the previous symptoms because they had them before, they had gone away, but they got it back when they were in a situation of stress. Okay, it could be a urinary tract infection, pneumonia, viral illness, hypokalemia, it could be anything, but it's not a new stroke. So that's the mimic. But it could also be a chameleon, it could be a new stroke. Okay, generally, patient that has, careful with this because you can have a new small stroke, and because you had a new stroke in a brain that had a scar, you can get the symptoms of stroke back. Okay, generally speaking, when this happens, they have new symptoms they didn't have before. Okay, this is the key. Something is new that wasn't there before. The vast majority of these people will need an MRI. Okay, that's the only way to know for certain. So I would say assume it's a chameleon until we can get more information. And it takes days sometimes to figure this out. So the only way to figure out whether symptoms are either new or pre-existent very early in the field is ask the person that knows the patient. Do you think this is truly new? Or, do you think they're at their baseline? Sometimes they have dementia and a prior stroke and they're bedbound, and it's very difficult for someone who doesn't know the patient to pick up these things. We ask the person that knows them. A lot of times the family comes to the emergency department, they're like, oh no, they are baseline, right? Whatever happened went away. And they have a lot of deficits. So person that knows them or the patient, if they are reliable, do you feel back to normal? Even though they have a lot of deficits. And that would be the way to go at the very early stages. And then obviously, a lot of times we need an MRI. So bring them in. Err on the side of caution. Okay, question number 6. I would like them to discuss how effective LAMP score is in determining LVO and how we can use it in pre-hospital care to guide our treatment plan. That's a great question, and a lot of people ask about pre-hospital scales. So there is a lot of data on pre-hospital scales, and unfortunately, what I will say is that pre-hospital scales are just a tool. Okay, they're they're a screening tool that is not perfect. So let's start there. And the data we have in sensitivity and specificity, false positives, false negatives, and accuracy is only based on the population they study. So you will see that it changes in different papers, okay? So don't be too strict about the numbers. But just to give you an idea, a lot of people ask, what about the NIH or the FAST score? So the FAST score is the best in terms of accuracy and easier to perform, okay? Easier to perform. That's why we use it everywhere in terms of picking up strokes. But for large vessel occlusions, yes, the lens is the one that is performing at a really high level. I would say almost like the NIH. Almost. So this is a very nice paper that looks at the cutoffs of different scales. So it's not just the scale, but it's the cutoff, right? Always keep that in mind. So the NIH, for example, I'll show you here on the very top. So if you do the NIH scale, it is not a pre-hospital scale. It's a very difficult, long scale. If you're really, really experienced, you'll probably do it in a minute. But it is a very difficult scale to learn. But let's say that's the gold standard in a way, or that's the one that we do with the more sophisticated one. A cutoff of more than 14 points. Okay, this is a very severe deficit. So you have to have a lot of deficits to have an NIH of more than 14. We'll give you more than 11 here. We'll give you an accuracy of 79%. Okay, but you will miss diagnosing about 27% of patients, and you will bring in, so if you use that for the pre-hospital scale, you will bring in 17% of patients that are futile. They didn't need to bring false positives. So what about if this is concerning, right? 27% will still have a stroke. Why? Because it's not a real good scale for posterior circulation strokes. There you go. Coming back to what's, the stroke we miss the most is the one that is the more rare and the one that presents in less specific ways. It's sort of the perfect storm, this posterior circulation stroke. So what about if we say, okay, well, what about if I bring down the false negatives? Okay, I'm gonna missing 10% of the strokes. Well, that will bring the fetal transfer rate to 46%, which is absolutely unacceptable. Imagine 46% of patients that are triaged and brought into hospital or brought into a large academic center, and they don't have large vessel occlusions, right? Cincinnati, pretty similar, 78% accuracy. But look at these, 35%. At the cutoff we use it, 35% of false negatives, okay? Again, likely posterior circulation strokes we're missing. Point down, please. This is the LAMS. LAMS is pure motor. The LAMS is simple, absolutely, but it's just motor. Face and grip, that's it, simple. Cutoff for 4 or more is a sweet spot where we have the highest sensitivity and specificity, 76, 71 is not 100%. The ideal score would be 100 and 100, total of 200. That would be the ideal score. Well, we don't have those kind of things. This is a very heterogeneous thing, the strokes, and they can present in many different ways. Accuracy is 72%. So it's similar to the NIH cutoff, more than 11, but it's a bit lower performing. But it takes 20 seconds. It's very easy, okay? So this is critical in pre-hospital setting. This is something we value a lot because time is brain. We just want to pick up these things. Remember, it is designed for ICA, MCA, and ACA only. There is no posterior circulation deficits here other than those that come in and present with weakness, right? Going down. So what I would say, how do we use them? Well, it's just a tool, okay? And actually, the author of this paper makes a very important point, which is what it boils down to. That, we can just send almost every patient to a comprehensive stroke center. Even the LAM score will overload most tertiary care centers if used widely, okay? So intracranial arterial imaging should be performed in all patients with acute stroke presenting within 6 hours of symptoms. So a lot of times is the fact that we need imaging ASAP. And that's the kind of final gold standard triage. But it happens when the patient is already in a hospital and identified as a stroke. Rhonda can comment on the LAM more than 4 in our region. In a bit, Rhonda, if you want to share what that the impact on fetal transfers, that we have the specific numbers to highlight this. I'll let her do that later, but it basically, it will be used to, I think, bypass some smaller centers, but it will be a very limited use. In the field, I think it will be more about increasing capacity on sites to do imaging very expeditedly. Question 7. We're almost running out of time. Differentiated vessel occlusions in the field. Okay, this brings me back to the same point, and I have a few thoughts about it. So please, next slide. The same point is that we want something to be very, very simple, brief, and identify patients quickly. Time is brain. Time is brain. Not the type of vessel occlusion. That doesn't matter. Just identifying a stroke is what matters, right? So what do we think about vessel occlusion? It is extremely hard to know what vessel occlusion. Sometimes we find it hard, although, we do this a lot. Ultimately, you get an angiogram, right? But I think it's perhaps even impossible. Why? Because different blood vessel occlusions can mimic other vessel occlusion. So a posterior cerebral artery occlusion can mimic a middle cerebral artery occlusion. An anterior carotid artery occlusion can mimic a middle cerebral artery occlusion. Differentiating an internal carotid artery occlusion with an MCA, also extremely difficult. An ICH can also mimic an ischemic stroke and vice versa. We're not good at saying, oh, with a high degree of certainty, this is one way or the other. Because the MCAs are more common, then that's more commonly what we see. And therefore, we're more likely to be right when we say it's an MCA. But that doesn't mean we're good at this just by looking at the patient. Most importantly, I think it's quite low yield, to be honest, for triage decision making. Anyway, they should be expeditedly, they should come in an expedited manner. The pre-hospital triage should be focused on identifying a stroke and quickly transported to the closest hospital, because without imaging, we can't treat. So that's what we want to narrow down. We want to decrease the time from the moment the person has a stroke to the moment they have that CT scan, so we can treat. We want that to happen quick. It could be an intellectually stimulated exercise. Everybody's happy to join us. Welcome to join us. We do this in the ED every day and try to figure out what vessel is occluded, but it's not really a valuable skill in the field. That's my thought. So next question. I think we're running out of time. Maybe we'll do this one. When paramedics arrive at the ER with a stroke patient, other than basic information and assessments we usually obtain on scene, which gets passed on to you during handover report, is there any extra information and assessments that we can obtain on scenes which will be helpful for the ER stroke docs? And I think yes. This is something we've been talking for a long time. Having the patient, when I get pre-alert and I have 5 minutes, having the name of the patient and the date of birth so I can actually look at the past medical history and already know who they are, medications, whether they have contraindications for TPA or allergies to contrast is extremely valuable. And I know there are barriers to this, but again, it is extremely valuable. Contact of the person who witnessed the event. A lot of times they come in, someone found the patient in the street, we don't know, we can't contact them. We need to obtain information firsthand. Because it changes the whole thing. A lot of times we find that it's not accurate, the information we're given, because it goes from person to person. So that would be extremely important. Maybe we can work on this. Maybe this is something we can work on, and to have a cell phone or some very private line where we can actually get information. This will actually, I think, translate into shorter door-to-meal times. Because otherwise we have to do all these after the patient arrived to AED, plus all the 10,000 things that we have to do. Next question. How to best deal with receptive aphasia? So we have seen a patient actually with receptive aphasia and how challenging it can be communication. So very, very timely question. So I have a few thoughts, to be honest. These are very challenging patients, right? Very, very challenging because you can communicate the regular ways. So you have to use, one of the things that we use is mirror neurons. So if you yawn, the other person will yawn, right? So we do have mirror neurons, and they are active even though when you have aphasia, because it's not the same pathway. So basically what you do, you show them what you want to do, and they will mimic you. It's not about understanding. It's about just doing what you're doing. So I stick my tongue out and I sort of ask them, oh, stick the tongue out, like, and just show them that that's what you want them, and show them what exactly, and they will do it. Most people will do it. Pull your arms up. So I just put my arms up and then, put their arms up and then show that this is exactly what you should be mirroring. And a lot of times we get around that. The other thing is you could get visual field testing. So you can check strength by mirroring and then visual field. We call it the blink to threat. So you can Google this. There is very easy ways to do it. Don't waste time asking to, follow any commands or tell you how many fingers they see. That I would skip altogether. Just blink to threat. So it's sort of pretending you're gonna touch their eye. You come from the side and see if they blink from both sides. and move quickly, right? You have aphasia, I think it's good enough. Not a lot more that we need, honestly. If I have someone who has sudden-onset aphasia, I don't care. That's a disabling deficit. That's a patient who will be given treatments unless they have contraindications. That is someone who should come ASAP. I don't need more information than the patient has aphasia. I'll be happy. All of us will be happy. Such a disabling deficit. Okay, next. I don't know if we have time. Do we have time, Tina?
Well, it's up to you, Dr. Kachinese. If you're able to
Okay,
stay for another 5 minutes, that's fine.
I'll take 5 minutes. Okay. All right, let's do this quick. Pre-hospital, what can we do for smooth and fast transitions? Okay, so we have a few thoughts. Next slide, get an accurate lesson. Well, I think somebody also asked about this. I would say here that actually we find this is the most inaccurate piece of information we receive. And why is that? Well, I think it has just boils down to asking the right question. If someone tells you, oh, at 5 p.m., I had right-sided weakness. Well, that means nothing to me as a stroke neurologist. I would say, okay, so what were you doing at 5 p.m.? Tell me what you did. Or if you want to make it really short, when was the last time you were moving, walking normal? And they will say, oh, that was like last night because at 5 I woke up from sleep, right? So when were you last normal? If they say, okay, I can't speak, well, when were you last speaking? Not when were you last seen by someone sleeping. When were you last normal is the most important thing that we have to get. And a lot of times, because people go by the onset that patients report, this is the place where we find that patients have been having symptoms for beyond 6 hours when they come in as a cold stroke. And that's okay. I mean, better safe than sorry. But if you're interested, what we do when we have a wake-up stroke or unwitnessed onset, we ask the patient if they are reliable, when were the last normal, and we're very clear. I'm like, when were you 100% normal? Okay, because they will say, oh yeah, in the morning I was okay. Or were you 100% normal? Oh no, I was actually off balance already. Okay, so when were you 100% normal? And just be very specific. People don't know what you're expecting, what kind of information you need. So you have to be extremely specific. If it is a witness or reliable patient, it's easy. They say, okay, I was eating and suddenly I developed this. And I will say, okay, at 5 p.m. you developed this. At 4:55, were you normal? I clarify that. And they will say, oh no, you know what? I wasn't. I already noticed I couldn't walk, but I didn't have right-sided weakness. Well, that's not the onset. When were you normal, right? So you have to kind of be a detective a little bit on digging into the last known. If patient is unreliable or you don't have any witness, this is truly the unknown onset, and these are very difficult. We generally go into detective mode. We go on the phone, last text messages, phone calls. We call family members and friends, and a lot of times we get information with that. Large majority of times we get information with that. Someone spoke to the patient, saw the patient. Sometimes they will tell us the last time we saw our mom was, the weekend, and that's the best time we have. But for the vast majority of patients, if you're really very detailed and you ask the specific questions, you'll get a very accurate last known well. I would say the other way to help, which I noticed perhaps could be, it definitely could be improved, is offloading the patients quickly. That's it. Our goal is to get that patient to the ED stretcher so we can start. And that is could be way shorter, I believe. So that's are the things that I think could ease this assessment for stroke. Okay, we'll get one more question in and then I'll open it up for questions. Okay, this is very easy. Difference in prognosis between hemorrhagic stroke and thrombolytic. Well, actually, so I thought about mortality. There's also functional outcomes. So basically, just as a ballpark, it's about the 30-day inpatient mortality is about 10% for an ischemic stroke, and it's about 30 to 40% for a hemorrhagic stroke. And if you have it in the brainstem, it could be up to 50%. So way more lethal way more lethal hemorrhagic stroke than an ischemic stroke. But generally speaking, if you go all the way up to 6 months, overall hemorrhagic strokes will see larger improvements in functional outcomes, because there is a lot of things that are reversible, like the blood will resolve, the swelling will go away, the elevated intracranial pressure will go down, and sometimes you're amazed at how these people do with hemorrhagic strokes. So that's to say not to give up too early on these people. They could really surprise you. Alrighty, so I can share the slides. The last questions are very, very brief, but I'm glad we went at least through the main things. And I hope this was valuable. I'm always happy to answer any other questions by mail. I did put my mail there in the presentation. Any questions? Everybody is very silent, so I'm not sure.
Well, thank you, Dr. Catanese, for taking the challenge of Stump the Stroke Neurologist. And I think it just fantastic. I know you are very busy and you've got to get to a clinic. So certainly you have your email. We'll share the slides, and if anyone has questions, we can get them to you. So we have a thank you. That was very informative. This was incredible. Thank you.
Thank you. My pleasure. Take care.
Okay, thank you very much.
Bye-bye.